Evening and good morning. Webinar series by Pakistan Children's Heart Foundation. Pakistan Children Akhtar. And let's start off with a brief introduction. Pakistan Children's Heart in Pakistan that helps fund surgeries and interventions for effects from lower socioeconomic backgrounds. It was founded by Farhan Ahmed, who was also a parent to a child with congenital heart disease. Pakistan Children's Heart Foundation, or PCHF, has four components: funds surgeries, which is known as Project Mohsin, and today surgeries. The second component is capacity building, or training to increase skilled professionals within the country, with 200 plus trainees and additional surgeries. Of is the hospital project, which is going to be the first strict cardiac facility in Pakistan. And our final project is the awareness, reach the community and increase the awareness of congenital heart diseases and the treatment options that are available to our patients. An absolute extraordinary and highly accomplished name in the field. It is an absolute honor and privilege for me to welcome Dr. Zahid Amin's webinar. Dr. Amin is a consultant pediatric cardiologist, also a professor of pediatrics, and is the recipient of and Chief of Pediatric Cardiology at Children's Hospital of Georgia at Augusta University. To his name in peer-reviewed journals. He is an accomplished expert speaker with more than sessions globally. He is a pioneer of the perventricular technique for VSD and membranous VSD occluder. And most importantly, he is an interventionalist by the Society of Cardiac Angiography and Interventions in 2007.
Thank you very much. I'm really humbled by this introduction. I see it's also online, Dr. Qureshi is online, and I see very good friends. Huram, good to actually see your name, if I can see your faces. It's been a while. The COVID has literally plans, so I did not visit Pakistan, I think, for the first time in so many years. Over when I was in Islamabad. So thank you very much. Samaa, you have been amazing and staying in touch with me. And this was really, really seamless despite me week schedule, the week that passed. It was unbelievably busy. So I don't have any talk prepared, as Samaa already knows it, but she had passed on to me some questions. I'll try to address, but I also would like the audience to ask questions and see what they can contribute to answering these questions. So you want me to go question by question, Samaa?
Start off by asking the first question, and
okay.
Again, sir, thank you very much. Have been able to take the time out to be part of this webinar. So let's start off with the basics. Could you please explain the different types of intervention techniques for congenital heart diseases differ from surgical treatment for congenital heart diseases?
The basic premise we should never forget: surgery started every type of repair. The longest, I should say, follow-up of patients, so has almost always been considered as the goal. In view, our objective was to be as good as surgery. To time, we may have surpassed some of the results that surgeons were able to provide. I'll give you simple examples of interventional closure of defects, for example. Simpler muscular ventricular septal defects. So these defects, which are definitely in Pakistan, very, very good interventionalists there, are the technique. These are the procedure. Atrial septal defect and PDA closure, I think the interventional results probably are better. Many views, if you will. One is you are avoiding the scar on the PDA. B is you're avoiding a scar in the middle of the chest if you were to and also you're going to avoid bypass. So why would I want the fact that I can literally close in the lab within 15 minutes from skin to skin? So the steps that surgeons take to close, for example, atrial septal defect or ventricular septal defects, and then closing the defect, we have really simplified it. We may want to make an incision. We have essentially a needle, in the groin defect, may it be ASD, may it be ventricular septal defect or PDA. So these simple techniques, I think, in so many ways. And there are other techniques where or the surgeons may not be as good. For example, paravalvular leaks. After placing valve, the heart is stopped. And those techniques, we are definitely better than them. And they will actually look up to take care of those defects. And then there are other techniques like branch pulmonary artery stenting. Pulmonary artery stenting, for us, it's complicated, but for surgeons to fix it may not be as good. So I think we can help them. So the for example, defects like that or paravalvular leaks, I think we are probably better like for paravalvular leaks type procedure. And then there are surgeries where, honest with you, there are cardiac defects where surgery absolutely is needed. Intervention and or surgery may be required in the subsequent years. And then the question.
Thank you very much. In fact, that is a very interesting post-operatively, because when we apply that to Pakistan, majority of our female patients, they report or they come to us for registration is post-operative scarring, because they have these stigma. Their daughters will not be able to lead a full life or to get married, and point which can be applied to LMIC. So organizations for like ASCs and PDA from PCHFs, day catheterizations are actually performed for PDAs and 30% for ASDs. So for catheterization in PDAs and ASDs, and a cardiologist decide to proceed with interventional treatment or surgical treatment.
So, for example, the PDA and ASD that you're talking about, they both will, heart has to struggle. It depends upon what chamber of the heart is suffering. So for atrial septal heart, that suffers because the blood that goes from the left atrium to the right atrium, then to the right ventricle, out to the coronary arteries. For the PDA, this blood that comes back to the coronary artery, and the left ventricle has to pump all the blood. So the ventricle that pumps is a ventricle that suffers, and that failure subsequently. So for atrial septal defect closure, they do well because this is a low pressure defect. And so they do relative 10% not as good as their colleagues or peers are as far as exercise capacity is concerned, several years. So if you see right ventricular enlargement, the recommendation now is that you can safely, we close these defects now even at 1 year of age. I know a lot of people probably don't like that. They like to where patients close. If I see a defect that is moderate size and we know we can, this defect will not close over age as well. But for sure, 99% of our defects we can close by 2 years of age. Suffer much faster, much earlier in life. They are sick. They're really, really, if it's a large PDA, will have issues, upper respiratory infections, all that stuff. That needs to be closed sooner. Significant patent ductus arteriosus needs to be closed much, much sooner. And that's maybe taxon because these patients come into the cardiologist site sooner. And like I was saying, they may be slightly symptomatic, but they may never know it, right? So it's very difficult. PDAs, because PDAs are more symptomatic patients, and they get there because to be a PDA is very much similar in congenital heart disease. So, for example, we do more ASDs in US. So that would be, because I think we can catch a lot more ASDs because fortunately, so we probably overdo. We'll try it as a reason. So the defects like in ASD patients that need to go to the OR have what we call secundum ASD. So if they have an ASD that is closer to the mitral and the tricuspid, one or both of them, so you don't want to close that. That's will be my first no. Then there are defects to the IVC, maybe the veins returning to the heart. Those defects in children will undergo surgery. Now, in adults, there are several physicians who have been doing now in adults sinus venosus stop ASD. AS data 2 to 3 years old, and it's a fairly cumbersome, fairly complicated procedure. But in pediatric patients, that's an absolute no-no for now.
Thank you. For comments, in terms of residual congenital heart disease, like you mentioned, safe to say that catheter-based treatments, they offer better quality of life for could you please mention how successful these interventions are?
So paravalvular leaks, Absolutely, if it significant issues. So, for example, mitral paravalvular leak is can cause significant left atrial, leading to heart failure type symptoms. So it needs to be absolutely addressed. Luckily, the paravalve leaks are not common in children because most of the valves are replaced when they're a little bit old, early in ACHD type patients, adult congenital heart disease type patients. And in them, they are really symptomatic with. So they are really symptomatic. And in those patients, because once you are able to close it, they can have symptom home and they will tell you next time, hey, I can actually breathe better. Actually, I did a case of Sadiq in Lahore about 3 years ago. And that was probably one of the younger patients. He was like 8 or 9 years old.
Definitely, he is an absolute giant in cardiology here. Really misses professionals like you. So what about you, Dr. Amin? Do you miss Baksan here?
Yeah, I absolutely miss Baksan. Why? I mean, every remember that, right? So in the heart, I'm always Pakistani. You know, every which way. Yes, I do. I do miss it without any question. But I mean, you know, I have contemplated honestly sometime that I could do that, and probably now that I'm getting older, once you know, and try to help as many people out as possible. I have been lucky, Karachi and to Islamabad and to wonderful people, especially Karachi. I started going there in like so between Dr. Patel and Dr. Mehnaz, I mean, we did hundreds of cases there. I mean, we used to have a 1 week workshop, like 16, but we would at least do 20, 25 procedures, in a week there, or even more. I have been able to help, but I definitely would like to do more without any question. I wish, you know, I have a contract with my hospital in such a way that they will allow me to do this, penalize me, if you will.
That is very promising, and that is something that there is absolutely no way we cannot talk about COVID-19 and how it has impacted management. From your position of leadership, can you share some of the steps you have had to take during this pandemic?
There are certain protocols that so put it simply, from March through June, there was not a single scheduled case that was done. So the lab, you were not allowed to do any scheduled cases because of when the lab opened. So it's a very detailed evaluation and COVID testing within 72 hours of coming to the hospital. Now, one of the other things that we did was that I think to simplify this question will be in such a way that in the COVID era, we have seen more issues after having COVID. Either they were symptomatic, were admitted, and the cardiac function, for example, heart rhythm related issues. Those patients, we asked them, the hospital told us not to actually go examine the patient. So anybody who would go there, to go there. So the precautions really to answer your question. They gave us specific masks to see these patients. We had specific gowns and notions. It is slightly now loose right now, although the number of cases are going up, slightly loose restrictions, but it definitely affected the quantity. Other than that, it did not, and it definitely affected the approach we were able to. Usually, if somebody calls us that they're not well, we'll try to schedule them tomorrow, for example. Associates here who I direct that they need to see. But at that time, we couldn't do it. Big lifestyle, but I think we are coming almost back to normal.
That's wonderful. Getting back to normalcy, and definitely everyone. All the people who actually went out, like you mentioned, the astronaut thing, the astronaut physicians, cardiologists. We're running a bit short on time. Before we move on to questions and answers, we're actually on the robotically assisted preventicular closure. Would you please shed some light on that subject? How have these advancements improved patient outcome for adopting such advancements in LMICs?
So the robotic assisted VSD closure was a research work that we did in pigs actually to see if it was doable, and we proved that it was doable. The problem was that the company machine would not want to make a machine that the diameter of the tube, the less than 5 kilogram baby. Because if you need to use robotic assistance to close a VSD, we need into some, then it's easier to open the chest or do mini thoracostomy and then do it. They have done some VSDs now in older patients. Our objective was younger. But what that made me learn and everybody around me was if you cannot do robotics. So now we do is a subcostal incision. The sternum stays intact. We go from below. Takes about 10 to 15 minutes, no bypass. What you call perventricular technique, but not using. It's really, really simple. It's really, really fast. So that's what we do now. We don't open the sternum at all. It did. I think what makes me most happy is that I wasn't the first ventricle, you know what I'm saying? But I was the first one who did an intervention while going across. I said, if you can put pressure, if you can measure pressure, why can't we close the defects? And it actually worked. Procedures are done every day all over the world using this technique. What the best part was that the valves that we cannot do in smaller children. Now we can do using perventricular technique. Child, we did this valve. The valve was a 5 kilogram. We opened lower part of the ventricle and put the percutaneous valve in the RVOT position. And they use the same technique now, perventricular valve for adults, and even mitral valve for using this technique. So segue, if you will, for people to think that okay, you can get there.
Wonderful. That definitely shed some light on the importance of in cardiology. But in terms of applicability, we would like to hear your comments in terms of cost, the alternative solutions which could be applied.
Sure. So both doing an ASD surgically and doing an ASD with a device. We have it with the device, right? But if you look at the problem in Pakistan, India, Bangladesh, all these countries, problem is that if you use a device, it's a lot more costly. It's costier than surgical technique, which is opposite to US. Here, surgery costs a lot less. Using surgical technique, it'll cost more than $100,000. Cancer technique is going to cost $50,000. Either way, it's expensive. But the point is, you're paying half the cost. Bangladesh, there the device closure is expensive because of the cost of the device. I think Pakistan has to talk with the companies to either subsidize the cost of the device, probably 10% of the cost. So if they sell it for $6,000, they should sell it to $100 to Pakistan, or you know what I'm saying. And I think they can do it because they know they make a lot of money. You know what I'm saying. I think they can do it without any questions. Second, I have talked about this several times with a lot of people. Lots of device, which and absolutely test it and will work. That even if you use the device in Pakistan, you'll be busy enough. And it can be totally living normal, decent life and yet helping everybody. That will to become self-sufficient. Have either talk to them, strongly. Hey, we would like to have a subsidized cost of the device, or we make our own. My suggestion.
That is absolutely wonderful. I think that lays down the groundwork and research implications for Pakistan, definitely. So thank you very much. I believe we should move on to our question and answer section. So let's. The audience, if you could please, yes, unmute yourself and you will be able to ask the question.
Farhan Saab and Zahid Saab, for your time. I have just one comment. Pakistan. Dr. Shaq is also attending the meeting, and Zahid. Let us have our Ministry of Science and Technology to develop. Very recently, we are listening from media that they have developed some. Why not the devices for congenital defects? As the government and the ministries to develop these devices, and this can cost cut.
If I can start, and I see Shaq is pretty face, so I can start, and definitely without any question, I completely agree with you. I think that Pakistan should be able to, and any which way, I can assure you that on speaking on behalf of Shaq, that he will help out in any which way possible to get this project. But I absolutely believe is the best thing. And there are so many ways to do that you upon very, very expensive devices that cannot be used. I mean, I know there are people in Pakistan who can absolutely afford Pakistan, who absolutely cannot afford it. And those are the people we need to help. And those we can help a lot less. Shaq, you want to comment on this?
So are less in contact with engineering people, that sort of close contact that will make things happen. And China, for that matter, valves have been developed and they're in use. Developed a valve both for surgical and they're working on a percutaneous. It really needs to be the local guys that are this webinar. They need to be in close contact with engineering university contacts, because it's those that will do the initial work before industry makes a commitment. And so it is possible, it is feasible, and that's the only long-term to be done in short term, but that would be the way to do it.
Right. I agree with you. Even Thailand, they make devices now. Vietnam, they make devices. Realized, okay, we really don't have to, if we can't afford these devices from high-priced devices, and with minor modification and all that to these devices, the concept, for example. So the concept, what it needs to be done, and you need to modify it and then make it. German, but they made it better. So we can absolutely do that. Need for valves, and I have seen valve from India. It's people will say it's similar to other valves. You cannot just generate some exotic idea for valve or device. So they are going to be looking.
Valves from China are similar to other valves developed in Europe and
correct.
US. So I know not long ago that there was a Pakistani firm or company that means that the technology is there, and it's a matter of just their approach a little bit towards pediatric cardiology.
I agree.
Dr. Baig, for your comments, definitely. And it is a matter of bringing together, and PCHF will definitely offer the groundwork for the suggestions and policy implications that you have laid out for everyone. And I think it's an exciting initiative to actually amalgamate the brilliance of all our worldwide. Let's move on to Mr. Farhan's question.
Assalamu alaikum, and thank you very much, Dr. Zahid, and all the valuable participants. I completely agree, and such a wonderful stuff. We are definitely trying our level best to get in touch with the UNUST, and if you guys can help us connect, I think this is the way forward. Really appreciate your suggestion and support. Thank you very much.
Have time for one more question if anyone would like to ask Dr.
Also, I see Khurram is on, and Amjad is on, and Amjad never stays
Sorry.
quiet.
I would like to ask Dr. Zahid a question.
I thought he was in bed.
In bed. He took a nap.
Yeah, Khurram.
Hello, Dr.
Hi,
Zahid.
Khurram.
Hello, Professor Sheikh. I would like to ask Dr. Zahid seriously of the possibility of making a Pakistani device. But how much devices would be consumed in a year? So we also who could help us making in helping starting this venture, but we that could be implanted in a year's time would be far less of making a device on our own, and that would not actually in the beginning, because then we would like to find out more markets, like the example that Thailand. There, one of the devices that we use is Cocoon's device, and we thought that we could not even find those markets. So how is it that we would be used only in Pakistan?
So I will start and see if Shaq wants to. I think Khurram, I remember that. I think Amjad had sent me an email. Remember that about this. You know, when Cocoon device was made, do you think they realized that they'll be able to think the competitive edge from United States? I mean, Europe leans on to US more, America leans on to Europe more so. So, you know, with Europeans available, the Cocoon device really was made for their own region, for their own country. It was used so many times and the results were so good and they were able to publish it that they could reach to other countries. And I think that's what if the quality of the device is good, and if your objective is not to just make money on day one, you know what I'm saying? I'm not saying you should make money. I'm going to make a good quality device. I'm going to work hard on this. I want to help people. I help people. I will end up making money. Because while helping people, I'm going to do such a good job of the mouth, and then suddenly people will say, oh, there is a Pakistani device that's cheaper and it has better results than this one. This is how it goes. Really, this is how it goes. Cocoon was not meant to be sold in UK, for example. Or, you know, Cocoon is never going to come to US. I could try and promise you that, because FDA won't let it in. Our device FDA hasn't allowed for the last 4 or 5 years. You know, so they may, in some parts of the world, it can go, and so can Pakistani device. But it's not that you will have to do a few thousand cases, great results, present, give the advantages of any device that particular devices are, and then of course it's gonna.
I think you made most of the points, but if I was just trying to think, and that's around between 65 and 70 million. Compare that with Pakistan, that's 2 million. So whatever the number of cases we do, Pakistan number. So immediately your numbers become different. And if the companies then use currently per year in Pakistan, because that is going to be an underestimate, because the service facilities are not yet widely available, but that's ultimately. So business wise, potentially there is the business about CE mark, the European approval mark later, because once using it and the word gets around, the companies start using it, and then they can start thinking about overseas investments, overseas. Did exactly that. It was used more widely in the Far East, and then ultimately they did, and now it can be used. It doesn't mean that it's used widely. Not as if they've made billions of profit from use in Europe. But it shouldn't be the only ideal, because in terms of population number.
Or between Pakistan and Bangladesh, for example. I mean, if you take what 400 million, right? In Pakistan, Pakistan and the Bangladesh, about huge population. Just consider these two countries. Forget India for now.
Yeah, India is manufactured. Now it's there are a few studies beginning to, but it's not something that is the target immediately. It takes a while to.
Right, I agree.
Thank you very much, Dr. I'm afraid that is all the time we have for today's webinar. I'm sure everyone has all our experts today. And again, thank you very much for taking the time out and answering all the questions. And inshallah, we do plan on hopefully Dr. Shakil Qureshi as our next guest speaker.
Absolutely.
Thank you very much, and Allah Hafiz.
Allah Hafiz, and shout out to you, Samaa. Thank you guys are doing in Pakistan, and God willing, in any which way we are able to help, we will be able to help.
I was going to say, but we've only seen a couple of them. The others are all muted.
They were muted. They're in bed, like Amjad was, you know.
All right.
All right.
Farhan
Take care.
and
Allah
Samaa.
Hafiz.
Allah Hafiz.
Okay.
Yes,